So let's start with APMPPE, or this is what we call as the acute posterior multifocal pigment Glucoid epitheliopathy. Now this is a syndrome which is usually seen in bilaterally. It is asymmetric, usually seen in young women more commonly. And there is definitely an antecedent viral illness. And when you see the fundus, there are different stages. You have these kind of creamy choroidal, creamy placoid lesions in the posterior pole. And when we see the fundus, there are varying stages of evolution. So this is what it looks like on FFA. You have hypofluorescent areas, and ICG corresponding, you have hypo areas. And towards the later stages, these start staining, but the ICG remains the same. And in fact, it shows more lesions on the ICG than the FFA. So this is a typical pattern. Fluorescent angiography shows block early and then stain later, and ICG shows more hypo and more lesions. And with time, the lesions tend to disappear on the ICG. And the autofluorescence shows a mixed lesions. You can have hypo, you can have mixed hypo and hyper, and usually there is a halo of hyper around these lesions. Now when we look at the OCTA, so this is something which has changed our thoughts about APMPPE, and again there is a disruption of the outer retinal layers and the retinal pigment epithelium, but this is something which we have started learning now, that initially we believed that APMPPE was a disease of the retinal pigment epithelium, but the OCTA now shows large choriocapillaries non-perfusion or flow reduction, and these correspond to the areas of ICGA. So therefore, now we've started believing that APMPPE could be more a result of choroidal or choriocapillary ischemia rather than a retinal pigment epithelial problem. So again, the acute phases resolve over weeks to months, and the larger lesions leave with deeper pigmentation. Now we use the OCT and FFA and fundus autofluorescence to monitor these lesions. So these autofluorescence lesions tend to persist and they don't disappear. The next white dot syndrome is the Serpiginous Choroiditis, and this has been described as large peripapillary helicoid lesions which extend from the disc. Now earlier it was thought to be autoimmune, but in India we started to believe that this could be due to tuberculosis, and many of our cases have responded to antitubercular therapy. And this is usually a result of inflammation of the choriocapillaries, inner choroid, and the retinal pigment epithelium. So this is a macular serpiginous-like choroiditis, where you have hypo lesions on fluorescent angiogram initially, and then they start showing late staining. And towards the edge, you start having hyper lesions like these, which are fuzzy. This is what you see in the active stages, and the FFA shows corresponding areas of hypo lesions. Now, autofluorescence is an important modality now which we have started using more often in following up these patients with serpiginous choroiditis. And this is a typical picture where you have these lesions healing and then you still have active lesions, and we titrate our medications accordingly. So what do you see on the OCT? OCT, again, you see the thickening of the outer retina, and this is what is called, the waterfall effect, which the pointer is not very strong, but in the choroid, and this is because of the hyperreflectance of the choroid. And what we see on the FFA, on the OCT, is disruption of the ellipsoid zone and the external limiting membrane. So again, OCT can be used, and usually OCTA have shown areas of choriocapillary non-perfusion, but the intervening areas usually appear okay. Now, these are again serial photographs of the same patient, though clinically it looks quite stable here, but the fundus fluorescent lesion, autofluorescence lesion still shows some activity. So we use multimodal imaging, especially if fundus autofluorescence and OCT, to monitor these lesions. Next other important feature is multifocal choroiditis and panuveitis. This is the picture, and the punctate inner choroidopathy. We do see a lot in our practice, and we have started to believe that this is part of the same disease but different spectra. These punctate lesions are usually associated with very minimal vitritis in comparison with the multifocal choroiditis, where you have a lot more vitritis. And nearly about 75 to 80% of these patients present with choroidal neovascular membranes, and this could be an important tool to monitor. monitor them. So this is one of the pictures which I've borrowed from one of the journals which show the fundus autofluorescent pictures, the late fluorescent angiography, and the ICGA, and one can monitor the CNVMs as well. Now this is a very interesting case which we had of a sympathetic ophthalmia with multiple white dots and progressive subretinal fibrosis. So these are associated with very poor prognosis. And you use, this is the FFA picture and the ICG. Unfortunately, at this particular time, we didn't have the OCTA with us. So we still don't know whether it is because of the choroidal granulomas or is it capillary non-perfusion causing these many hypo areas. The other important white dot is the mutes, which is usually an acute multifocal unilateral disease, which usually occurs in young women, and there is a prodrome of a viral illness. And one of the important clinical variant is this foveal agranularity. You can have very tiny dots like this, or it can be some things like these placoid kind of lesions. And this looks quite similar to what we see in APA and PPE as well. And again, the fundus fluorescent angiogram shows these wreath-like pattern of hyperfluorescence. And when we do the autofluorescence, though there aren't many lesions, at least we believe that there are no lesions here clinically, but the autofluorescence shows much more lesions than what we clinically see. And here you have these kind of hyperreflective material on the retinal pigment epithelium, breaks in the interdigitation zone, and also in the ellipsoid and the external limiting membrane. So these usually have a good prognosis, but what is something interesting in this is we initially believed that this could be a choriocapillary non-perfusion, but the on-phase OCT has shown these kind of lesions, hypopigmented lesions, and the choriocapillary level is otherwise normal. So mutes is probably as a result of sick and mottled RPE rather than any choriocapillary issues. So again, these patients have enlarged blind spot. So these are changes which our thinking about these disorders have changed with the advent of OCTA. Again, this is something which we don't see in our part of the world because we don't have this HLA-A29 predisposition. These patients are associated with poor vision. There's a lot of vitritis and retinal vasculitis in these patients, and they require immune suppression. So these are the pictures which I borrowed from Dr. Rao. Classical, you have these creamy lesions. They radiate from the optic nerve head. And the retinal vasculitis is an important component of birdshot, and the fluorescent angiography is used to monitor these lesions and whether they're responding to immune suppression. And again, ICG shows hypofluorescent lesions, and these lesions tend to reduce with therapy. And OCT is an important tool because CME is one of the major causes of visual loss in these patients, and this can be used for monitoring them. Again, this is how the pathology. Unlike the other white dot syndromes, birdshot, they have had autopsied eyes, and this shows both non-granulomatous and granulomatous inflammation in the choroidal area, and also around the retinal vessels, which could contribute to the retinal vasculitis. Again, there are mimickers to the white dot syndrome. For example, this patient with sarcoid granulomas, and one can see large granulomas in the OCT. And again, this is another patient who just presented with just disc edema, and there are, the ICG shows many hypodots, and these can be followed up with treatment. Now, based on the better understanding of the pathology in these eyes, a newer classification is being proposed: Uviatic syndromes with choroidal-based pathology, which includes sympathetic ophthalmia, or systemic syndromes with choroidal-based pathology like VKH or sarcoid. And depending on where the pathology is it outer retinal or choriocapillary-based pathology? Again, multifocal choroiditis without vitritis, where PIC and histoplasmosis fit in, and with vitritis, where all the others fit in. And of course, you have other mimickers like the neoplasms and infections. So we have a long way to go, but this has laid a path for us to understand these diseases better.